All right, you ready?
Good afternoon, everyone. Welcome to today's Endocrinology Grand Rounds. We are very happy to have Dr. Harold Bays present today's topic. Dr. Bays is the Medical Director and President of Louisville Metabolic and Atherosclerosis Research Center. He is a Kentuckian. He also studied at the University of Louisville Medical School, did his residency and fellowship here. He was also been in practice in Louisville since finishing his fellowship. His main work has been in the field of clinical research, has built this, the Louisville Metabolic and Atherosclerosis Research Center, has conducted over 500 clinical trials and has published over 300 papers from the work that has been done in this field, particularly in areas related to diabetes, obesity, and lipids. He's also been very active in the Obesity Society, the Obesity Medicine Association, where he has served in leadership positions. He has also been a recipient of several awards from these different societies. He's also board certified in clinical lipidology and has been on the board of the National Lipid Association. Today, he will be talking to us about body composition analysis and implications for patients and athletes. Thank you, Dr.
Thank you, Sri. Thank you very, very much. Okay, I've been told to ensure that everyone puts their microphones on mute because apparently we can hear something here. All right, so my name, as I mentioned, thank you for that introduction. As was mentioned, my name is Harold Bays, and I'm medical director of a research facility. And I'm very proud to be on the clinical faculty here at the University of Louisville in the endocrine department, so that's very nice. If you're looking at the camera, probably a little ghostly, okay, but that's the best we can do with the lighting that we have. But it's just great that people are able to remotely log in. I was logged in last week, and it was great. Carla gave a great presentation with regard to diabetes last week. This one's going to be a little different in that the genesis of this presentation, I was speaking to Dr. Moshe Gundam about what is of interest to the folks here at the University of Louisville. And they said, well, we have some abstracts coming up and such. And I'm going to mention those later on, not the results, but just the skeleton of the abstracts, because I've done some work within this area of body composition, and that's applicable to those particular abstracts. The other thing is, it just so happens that one of the patients that we just saw a few days ago, fit this presentation exactly. So this is not so much going to be a take a bunch of notes and write down a bunch of facts and figures and data and such. This is to give you a perspective about body composition that either maybe you haven't thought about or maybe you haven't had that type of experience. That? There we go. Yeah. I had to click on it. Yeah. So we do body composition analysis. That's what we do. Our research site does it. We also offered it. We also offered it to the public. So that's in my disclosures. So at the conclusion of this presentation, you're going to know a little something about percent body fat. You're going to know about visceral and android fat. You're going to know a little bit more about body composition, what it means to your patients, and particularly with athletes. So let's talk about March 31st. Just a few days ago, a 33-year-old Hispanic woman with obesity began a rigorous nutrition and physical activity treatment plan. And she felt like she'd really been adhering to this treatment plan, and her frustration is that she was doing all the right things, that she thought she was doing all the right things with regard to nutrition and physical activity, but she really wasn't losing weight like she thought she would. And she thought there might be a endocrine cause for her obesity. Okay? So there's the setup. So before I get to what we did and the plan, let's talk a little bit about the pathophysiology of obesity. So here is the Obesity Medicine Association definition of obesity. So I was the writer of the Obesity Medicine Association obesity algorithm, and this is where this came from. And we had a bunch of authors, and I said, okay, we need a definition for obesity because there really wasn't a good one out there. And like all 6 authors sent me 2 pages of what they thought a definition of obesity was. I said, we can't have a definition that's 2 pages. It's not going to work. So we distilled it down, and finally, after a series of weeks, this is what we ended up with. I think it's pretty good. Obesity is a chronic, progressive, relapsing, and treatable, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. So there's a lot packed in that definition. And as you know, when you do get an increase in the obesity, adipose tissue and adipocytes very active. They're very active from a hormone standpoint, very active from an immune standpoint. And you can have kind of a dividing line, although it's not always so divided all the time. But for the purpose of concepts, you can have the sick fat disease, what I call the adiposopathy, where you have the abnormalities in the glucose, the blood pressure, and lipids, and those types of things. And then you can have the fat mass disease, which these are the biomechanical structural abnormalities, problems with mobility, sleep apnea, tissue compression, these types of things. As far as adiposopathy, it's very interesting that this concept of sick fat is something that I originated almost 20 years ago. And back in the day, people didn't think obesity was a disease. People were adamantly opposed to that sort of concept. And I'm like, well, that makes any sense. I mean, if you have an enlargement of your heart cells or enlargement of your heart, you got no problems calling that cardiomyopathy if it doesn't function correct from a biomechanical standpoint, or it doesn't function correctly from a mechanical standpoint. That's the very definition of cardiomyopathy. So why do you have a problem with enlargement of fat cells, enlargement of adipose tissue that is, not functioning and causing adverse consequences to patients? Why is that a problem? Still don't get it, but the world's coming around. So adiposopathy, or sick fat, is defined as pathogenic adipose tissue anatomic and functional derangements promoted by positive caloric balance in genetically and environmentally susceptible individuals. It results in adverse endocrine and immune responses that contribute to metabolic diseases such as the diabetes mellitus, hypertension, dyslipidemia, cardiovascular disease, and cancer. And here's that whole, that diatribe I just went on about cardiomyopathy, where there's just that analogy between the enlargement of the heart, we call it cardiomyopathy, enlargement of adipocytes and adipose tissue, we call that adiposopathy. There's all sorts of other ones out there too. One of the criticisms that I've heard is that adiposopathy is hard to say. Have you ever tried to say ophthalmopathy? I just think that's a much more difficult word to say than adiposopathy. Okay. Plus, I think that's hardly a good reason to deny the pathogenic potential of enlarged adipose tissue. All right. So here's another claim that I made. This was way back in 2004 when I was talking about investigational anti-obesity agents. And I saw this coming, like I said, about 20 years ago. The emerging concept is the development of anti-obesity agents must not only reduce fat mass, the adiposity, but must correct the fat dysfunction, adiposopathy. So it isn't just about the weight of patients, it's about the health of patients, right? So you can turn this on its head. How does pioglitazone work? Well, one of the things that pioglitazone does is it increases the proliferation and differentiation of new fat cells. And by providing more functional fat cells and more functional adipose tissue, you improve the diabetes mellitus. You can take atrophic mice, blood sugar is going to go through the roof. You transplant fat into them, blood sugars go down. You see? So you must, and you've seen patients with lipodystrophy. You may want to say, well, if they have lipodystrophy, they don't have as much fat, then metabolically that'll be good. No. They have insulin resistance, maybe diabetes mellitus, and these types of things. HIV lipodystrophy. I mean, there's all sorts of these examples out there where it isn't just about fat mass, it's about fat function. So in the typical way that we see patients, what happens? Well, you have a genetic and environmental predisposition, unhealthful nutrition and physical inactivity, positive caloric balance, and you get the adipocytes enlarge, the adipose tissue expands, and the endoplasmic reticulum doesn't work, and the mitochondria don't work. You call it mitochondrial stress. You've probably heard of that. And if you have relative impairment of your ability to differentiate and proliferate peripheral subcutaneous adipose tissue, where's that excess energy going to go? Where's it going to go? It's called energy overflow. And here's where it's going to go. Those free fatty acids are going to go to your liver. And those free fatty acids are going to go to your muscle. And what does that cause? It causes insulin resistance and contributes to the type 2 diabetes mellitus. It might also go to other fat depots, which aren't supposed to be there. Might go to your viscera. Might go around your heart. Might go around your heart. Isn't it interesting? Direct correlation between the visceral fat in the abdomen, and the visceral fat, it's called epicardial fat, around the heart. They directly correlate. And a collection of visceral fat also correlates with what? Coronary calcium scores, as does epicardial fat. See, they're all connected. All connected. So given that visceral adipose tissue accumulation may be the result of limitations in subcutaneous adipose tissue proliferation and differentiation during positive caloric balance, then an increase in your visceral fat accumulation might be considered a surrogate marker for global fat dysfunction. Too many times you hear people say, oh, well, the only thing you have to worry about is that visceral fat. No, not right. It's the entire organ. Okay, it's the entire adipose tissue organ and how it functions and the crosstalk and the interaction between the various fat depots. So it isn't just visceral fat. And let me just give you a practical example. We just went through COVID-19, right? Just went through that. Who is it that got COVID? Who is highly predisposed to getting COVID and doing very poorly? People with the obesity. Now you might say, why is that? Well, there's mechanical reasons, just like I talked about, impaired lung function and these types of things. But in addition, people with the obesity have impaired immune function. But the thing with patients with obesity, it's a paradox, because not only do they have impaired immune function where they're susceptible to an infection, they get the double whammy. And the other whammy is, once they get infected, they have an exaggerated pro-inflammatory response, and that results in severe lung dysfunction. And I think we've seen that in our patients. All right, so let's just get to it. Here is a picture of a dual X-ray absorptiometry. This is our DEXA machine right there. So you're looking towards the back of the building, that picture you saw. And there's the computer, and then this is that scanner goes across a person's body. And there's all sorts of other body composition analysis, and just DEXA. In endocrinology, or at least in my world, that's the one we use the most in research. But there's other ones. I've done calipers on myself. They're fine, but they're very difficult to reproduce. And if you don't have the same person doing it, very challenging. And also, they don't correlate very well to really objective measures. But I have found them useful that once you get an objective measure, as long as you know what the variance is going to be, I think calipers have their place. Air displacement, plasmography, BOD-POD, you probably heard of that. Bioelectrical impedance devices, a lot of people have those at home. And I think what we're going to talk about, one of the abstracts was done here at the University of Louisville, used bioelectrical impedance. And the thing you have to be careful there, the range of pricing with bioelectrical impedance, I mean, you can get very, very inexpensive and probably not so good devices, but then you can get state-of-the-art devices, which some of them cost about as much as DEXA. Okay, so again, there's just wide variance in the cost of the machine. Then there's underwater weighing. I don't know if they still do it, but somewhere here at UofL, way there on Shelbyville Road, they used to do underwater weighing, and they probably still do. I just haven't checked into it recently. And then there's still people that do the CT and MRI. And again, that's mainly in a research setting. Deuterium dilution hydrometry, I mean, I've never done that. But there's some people overseas and such that do that mainly within research. Here's one that may shock you. You say, well, what about just waist circumference? What about waist circumference? Okay, isn't it true that particularly with men, they collect it here in the apple distribution, right? You've heard that. And women, more in the gluteal area and the peripheral subcutaneous adipose tissue. So that's the pair distribution. Well, there we go. Doesn't that solve it? Does not solve it. The correlation between waist circumference and visceral fat, wide variance. Many times doesn't correlate well at all because it depends upon sex and it depends upon race. We're going to get into that. So there used to be these other definitions for percent body fat. The Obesity Medicine Association, we said it was time to move on. A overriding thing I'd like to get across is that percent body fat is really good as a descriptor, very good as a diagnosis of how much body fat you have or the percent body fat. Not so good with prognosis, not from a cardiovascular standpoint. There you really do want to know what the visceral fat is. And if they don't, if you know that there's this wide variance between percent body fat and even waist circumference to visceral fat, then you do have to go that one step further if you want to get prognostic measurements. But nonetheless, we came up with these criteria. Notice they're all on, fives and zeros. A lot easier to remember. And it just so turns out that if you look at one of the objections I had, I don't know if you've ever had your percent body fat done, but for men anyway, there was this leap from acceptable to obesity. Like there wasn't a pre-obesity, there wasn't an overweight. They just threw obesity at people. And obesity has meaning, right? So we come up with this term, the pre-obesity. But if you look, the criteria greater than 25 kilogram per meter squared is overweight and greater than 30 kilogram per meter squared is obesity. Well, it just turns out that's pretty close to the same thing for percent body fat for men. So you can remember it. These are easier to remember. So I don't even remember the other cutoff points now. I remember this because it's easy to remember. And then you add 5 percentage point for women. And you're done. Okay. And here's the android and visceral fat. We like to have visceral fat being less than 1 pound and android fat being less than 3 pounds. Really easy to remember. Now you might say, well, wait a minute. Is it possible that any amount of visceral fat, that there's an exponential increase in the risk of heart disease, metabolic disease, once you start getting any kind of collection? It doesn't have to be a pound. And that's a fair point. We just don't have the data. And so given that we do a lot of DEXAs, given that I can count on one hand how many men I've seen with zero visceral fat. A lot of women have zero visceral fat, not men. The idea that you would come up with some sort of unrealistic expectation with that data to back it up just seems sort of silly. So less than 1 pound. That's pretty good, okay, for both men and women. And then, as I said, less than 3 pounds for android fat. So here's a look. If the endocrinologists aren't getting excited about obesity, better watch out, because just like with diabetes, cardiology people getting very excited because we got all these outcome studies that are getting ready to be reported on anti-obesity agents and heart disease. And just like, you see how interested cardiologists are in SGLT2 inhibitors? You see how interested they are in GLP-1 receptor agonists? That used to be our domain. Not so much anymore. But if you look at the data that comes out with SGLT2 inhibitors, is there more endocrine data being generated or more cardiology data being generated? Right? And there's reasons for that, and I'm not objecting to that. And I think it's great that the cardiologists are taking it so serious, but we've got to take it serious too, as endocrinologists. And this is actually just to give you an idea, this was just published, I think, a week or two ago in JACC, Journal of American College of Cardiology. And they asked me to do an editorial on the effect of sleep on visceral fat accumulation and what does it all mean. And here's just a picture of all those things DEXA. I gave a presentation. I went through an entire presentation, seminar I'm doing now, and afterwards people came to me and they said, DEXA, what does that have to do with body composition? Like, what do you mean? DEXA, isn't that just bone? And it never occurred to me that people only associated DEXA with bone and had no idea that it had percent body fat, android fat, visceral fat, lean body mass. Okay? Not everybody knows all this stuff. All right, so let's look at some, I think, kind of fun clinical like applications. Here are data regarding the Green Bay Packers football team. Okay? If you look over here on the right, look at the wide receivers and defensive backs. You can see here that they have 12 to 13% body fat. So that's elite level. Well, of course, they're professional athletes. And look at their visceral fat, 0.7, 0.7. So hardly any visceral fat. And you'd say, well, they're elite athletes. Of course, that's what you'd expect. Okay. Have you ever seen offensive and defensive linemen? It might surprise you. If you look at them, you might have one opinion. But if you objectively assess them with DEXA, what you find is, look at defensive linemen. Visceral fat. Here you have 2 pounds. So yes, it's above 1. But I think if you were to just look at people, defensive linemen, you might have a very different prediction about how much fat they have. I mean, we're going to get to it, but some people have well over 10 pounds of visceral fat, okay? But not these folks. And even the offensive linemen, visceral fat, 3 pounds. Quite remarkable. So that's how your eyes can be very deceiving. All right, so principle 1, a focus on BMI maybe is misleading in patients with increased muscle mass or patients with decreased muscle mass. I mean, look at these people's BMI. Offensive lineman, 38 kilogram per meter squared. That's way in the obesity range, right? Greater than or equal to 30 kilogram per meter squared is obesity. Look how far away they are, and yet that's not the whole story, is it? All right, so let's take another one. Here's a 23-year-old white female bodybuilder. She goes to her clinician. They find that she has a body mass index of 27 kilogram per meter squared, and they tell her she's overweight. Fortunately, she was pretty good about it. She could have just gotten really upset, but she didn't. She came in and got a DEXA. And what did she find? What she found is she had 123 pounds of lean mass, which is pretty good. Lean mass is going to be things like your organs and such, but any change here in lean mass in most cases is going to be muscle. Okay. Percent body fat was only 28%. And look at that. The android fat, 1.7 pound, visceral fat, 0. Zip. So even though her BMI was in the overweight category, her percent body fat was well within the acceptable category, and she met every other criteria for very healthy profile with regard to her android and visceral fat. So what's the deal? Why is her BMI high? Because she had muscle. She was a bodybuilder, right? And I don't want to get people all riled up or anything, but I have never had a male bodybuilder who's come to me and said that the doctor told them they were overweight. Okay, but we have with women, okay, because that's just not something that people still expect nowadays. Okay, so a focus upon BMI may be misleading when sex and muscle mass are not considered. All right, so let's just talk about males for a while. So here's a black male. This is the highest amount of lean body weight that we've seen years that we've been doing this. 185 pounds. If you look at the bottom here, NFL offensive linemen can have greater than 200 pounds, but I got to tell you, 185, that's a lot. That's a lot of muscle. But if you look at percent body fat, 18%. That's fitness. Look at the BMI. Again, well within the obesity range. But is this person obese? Of course not. Of course not. And look at that, 0 visceral fat. That's one of the 5 men patients that I've seen that had 0 visceral fat. This is one of them. But obviously a big-time athlete. Asian male. Why do I bring that up? Well, look at the body mass index. Not that much difference. 35 kilogram per meter squared. But look at the android fat. 16 pounds. Look at the visceral fat. 4.2 pounds. I think most people in this room know where I'm going with this, right? There's genetic predisposition among particularly South Asians, but East Asians as well, for collection of adipose tissue within the abdominal region, and particularly in visceral fat, which is why for South Asians, increased risk of diabetes and cardiovascular disease, and for East Asians, increased risk of the diabetes mellitus. Okay. Now here's a white male. This man, body mass index 46 kilogram per meter squared. So, oh my goodness, we got to do something here. So that's well within the obesity range. Percent body fat, 48%. But isn't it interesting that if you look at the android fat, 17 versus 16, talking about Caucasian versus Asian on the android fat, and if you look at percent body fat, 48% body fat for the Caucasian white male, 45% for the Asian male, but yet the BMI is almost 10 kilogram per meter squared difference, just showing the profound effect of race on body composition. And that's the reason we have different cutoff points for body mass index and such, and waist circumference for those of Asian descent, right? Different cutoff points. So BMI can be misleading when not adjusted for race. And for those of you who are interested in diversity and in obesity and how metabolic disease differs, we just got through publishing a series of the relationship of obesity to Latinos, differences in sexual orientation, blacks, Native Americans, South Asians, East Asians, Mediterranean region, and Middle East. And they're all published, and they're all free online. So these are round tables. So they're very practical, where we took experts and people that actually come from these areas or have or descended from these areas. Give me very practical advice. Okay, here's a 28-year-old black female. Body mass index 32 kilogram per meter squared. So that's obesity, right? That's obesity. Lean mass 135 pounds. That's a lot of women athletes. That's on the higher end of even women athletes. Okay, but she's black. So blacks do tend to have an increase in muscle mass compared to whites, right? And then, probably does exercise too. And here you can see her android fat is 4.7 pounds. It's a bit over 3, but not that bad. And look at that, visceral fat, less than 1. So her BMI is in the obesity category, but her percent body fat's in the pre-obesity category. And her visceral fat is less than 1 pound. So she has a mix of a healthy and unhealthy body composition. So focused on BMI may be misleading if you're not taking into account sex and race. 52-year-old white female, body mass index 28 kilogram per meter squared. Right? So that's overweight, but it's certainly not with obesity. Yet her percent body fat, 46%. So she clearly, look at that, only has 79 pounds of lean mass. She has sarcopenia. So you would never know that. You would just say she's modestly overweight, and you would have no idea that her percent body fat is 46. So her percent body fat way in the obesity range, but her BMI was only in the overweight range. And her android fat was only, that's very high, 5.4 pounds, and a woman is very high, and the visceral was 2 pounds. So that's an unhealthy body composition. You would not know that simply by body mass index and a weight. So while race is important, the diagnostic and prognostic value of body composition of females of all races may be especially important. If this were a male and he had a 46% body fat, who knows how much visceral and android fat that would be? Have to be careful. Okay? So while more accurate than body weight or BMI, percent body fat remains primarily a descriptive diagnostic measure of adiposity rather than a prognostic measure for cardiovascular risk. Measurement of specific fat depots, such as the android fat and visceral fat, better correlate with cardiovascular risk. Here's a 29-year-old white female. Body mass index, 21 kilogram per meter squared. Looks good. Weight, 130 pounds. Lean mass, 91 pounds. That's up a little bit there. Percent body fat, 27. Looks good. Android fat, 1.3. That's great. Visceral fat, 0.05. Looks great. So the BMI is normal. Looks good in the normal range. Percent body fat looks good. Android fat looks good. Visceral fat looks good. Well, BMI is not always misleading. Okay, so you got one right. If you just did a scale, you got this one right. Did okay here. Here's one. Let me see if this is the. Oh yeah. So here's a fellow got his DEXA done. Body mass index, you can see here, 28, 27 kilogram per meter square. But he had 7.4 pounds of android fat and 3.8 of visceral fat, and he gets 9 pounds of weight loss, and he maintained his lean body mass, which hardly ever happens. That's the reason I'm presenting these, because that never happens. If you lose body fat, you're going to lose body muscle. That's just how it normally happens. But he didn't. And he maintained his lean body mass, and he was able to reduce his android fat from 7.4 to 6.5. That's pretty dramatic. And he was able to get a half a pound off of his visceral fat. So which is more impressive? To tell your patient, you went from a BMI from 28 to 27. So congratulations. Or is it better to say, you lost 9 pounds of fat? Which is more motivating? Which is more rewarding? Which is more accurate? So focus on BMI may not be optimal to assess response to treatment. This is one of the most, again, some of these are the extreme. In fairness, I'm picking some of the extreme. This is, thus far, one of the most extreme situations that we've had. 40-year-old comes in, got a body mass index 36 kilogram per meter squared. He was a former, sort of athlete, a big-time mountain biker. Big difference between mountain biking and bicycling. Bicycling, as you know, for those of you who are interested in bone, really doesn't help bone very much, right? Mountain biking, very different, you know what I mean? Because there's a lot of compression and, anti-gravity movements and these types of things. So it's a very different sport. It's not the same thing. So anyway, that's what he used to do. Lean mass, 165. So that's up there. That's in the athlete range. And then his android fat was 12. And once you get this degree of weight or whatever, we can't measure, the machine won't measure the visceral adipose tissue. So his BMI is in the obesity category, percent body fat's in the obesity category, and his android fat is about 4 times the goal of less than 3 pounds. So this guy's a mess. Okay, he knew it. That's the reason he came to us. I got to get it fixed. 3 months. Some of you might ask, how long does it take if you really were to train, make a difference? 3 months. In 3 months, he lost 12 pounds. You might have said, well, that's impressive. It's not that big of a deal. Not if you do DEXA. He lost 20 pounds of fat in 3 months. And he gained 4 pounds of lean mass, which I would assume to be skeletal muscle. That never happens. Okay, so we never see this. This was quite remarkable. So yes, he's still in the obesity category from BMI and percent body fat and whatever, but my goodness, to be able to tell a patient that they lost 20 pounds of fat and gained muscle, that is a good day to be a clinician. To reward a person for can you imagine the kind of work and effort it took to do that? So it's not that the BMI was misleading. I mean, he lost 2 kilogram per meter square, but that just doesn't sound near as impressive saying he lost 20 pounds of body fat, increased 4 pounds of muscle. Now, a lot of you might say, well, the reason he was able to maintain that muscle or increase is because he's got muscle memory. You probably heard that term, right? Muscle memory. That's where that if you've had a lot of muscle in the past and then you didn't train, it's easier for you to pick up the muscle again if you start to retrain. And there is some evidence that may be true, at least in animals. What happens is you build muscle, you build nuclei, new cells, and these types of things, and then maybe it's easier to build upon those cells. But I would just echo the last bullet point there. Whether the postulated mechanism also holds true in humans remains largely ambiguous. So I don't know that that's true, but you'll hear that a lot. You'll hear the term muscle memory a lot. Okay? Is it true or not? I mean, I don't know. The other thing is, whenever you're considering the effects on body fat and muscle, you really got to pay attention to the neuromuscular units and adaptations and everything. If you lose weight, what happens to your muscles? They become more efficient, which means even simply by just losing weight, now you're going to have to exercise more to burn off the same amount of calories that you did, when you weighed more. So that makes it very difficult to maintain weight loss because now you're burning off less calories for the same amount of movement. Your muscles become more efficient. And chronic physical exercise also results in greater efficiency. Increases in muscle mass occurs more readily at the start of a resistance program. Many of you that have done resistance training know that's to be true. You can start off and you can put on muscle pretty quick and you're all proud. But if you become an elite bodybuilder, if they can put on 1 pound every 6 months, they're happy. Because there comes a point where you hit that genetic ceiling and it's just not going to happen for you unless you take certain substances, right? Anabolic steroids or whatever, and then you can push it higher. And that's why a lot of them do, because you're banging up against the ceiling. It's just really hard to break through. And then the other thing is, and I don't want to ruin everybody's day here, but muscle is rapidly lost with detraining and immobility. 2 weeks of immobilization can reduce muscle mass by greater than 3% and markedly reduce muscle strength. I mean, matter of fact, he was just in the office today to get dietary counseling. We did Dexon on a guy about 2 years ago. He came back in last week. He had lost 30 pounds of lean mass because and what did I see when I looked at the DEXA? Had a big metal something on his knee, right? So his immobility quickly drained him of his lean body mass, and so now he's trying to get his muscle back. So he's meeting with the dietitian to see what to increase his weight because he had lost a lot of weight, and a lot of it was muscle. Okay. All right, so let's get back to our case. Again, just seen right here. This woman, 33-year-old, she says she's done the resistance training, done the appropriate nutrition, can't seem to lose the weight, but then she says this: even though I'm not lost weight, my clothes fit looser around my waist. So what does that suggest? That suggests she's putting on fat and losing. She is putting on muscle and losing fat. So it would have been really nice if before she started this, I think it was like 6 weeks ago or something. It would have been nice if she'd gotten a body composition at the beginning, because now she's probably well into really achieving a lot of her gains. So even if she were to get a body composition analysis now, it's just not going to be as rewarding, going forward. It's going to be harder. Okay. But because this is an endocrine clinic, you got to do something. You can't just say we think you're gaining muscle and losing fat, and we're not going to do any workup. I don't think that's going to fly in an endocrine clinic. You do have to do some sort of work. So what are the primary and secondary causes of obesity? Well, the good news is there are hardly any. That's the one nice thing about, if you had to pick something nice about obesity, it's a horrible disease, but diagnostically, not a whole lot of things. There are a lot of genetic syndromes that can do that. There's an endless things, but the amount of people that have genetic syndromes, explicit genetic syndromes, very rare. Okay? So yes, there are some isolated, non-inherited genetic abnormalities like Prader-Willi or familial abnormalities like melanocortin-4 deficiency. If you encounter everybody in their family has the overweight or obesity, you want to look at that melanocortin-4 receptor deficiency. But here are the medical conditions. So hypothalamic damage, immobility, insulinomas, and other hyperinsulinemias. How many of y'all seen insulinomas? Oh, well, of course you. I remember when I did. We saw insulinoma, we saw mastocytoblastosis, we saw all these kind of hyperinsulinemic states. Very interesting. Some cases of hypothyroidism, I've seen just as many people with profound hypothyroidism who have lost weight as gained weight. Okay, so that's tough. I know everybody wants it to be the thyroid, and yes, you can come up with specific examples where that happens, but I wouldn't bank on it. Okay, Cushing's disease, sleep disorders, and then the obesogenic effects on medications. So what did we did? Yes, we did the thyroid blood testing. We did 1 milligram overnight dexamethasone, but we did recommend body composition. I didn't tell her that I do it at my site and give her my card or anything. I felt that was like conflict of interest. I just told her to search around on the internet and find out if she wants to get bioelectrical impedance or DEXA or bod pod or underwater weighing, whatever she felt. Okay. What about body composition and nervous system and psychiatric disorders? Well, this goes to and maybe some of you here that are on this abstract. This is abstract going to be presented in Endocrine Society this year, and the background is with increased survival after acute injury, cardiovascular disease has emerged as a major cause of mortality and morbidity in spinal cord injury individuals. So, at least to the abstract that was provided to me, body composition was measured by DEXA. Mean age was 34. That's so tragic. Because who gets the spinal cord injury? Many times it's younger folks who get in bad accidents and whatever. And so the body composition analyses were done. Now that you've heard this presentation, the data is going to probably make a lot more sense to you than before, otherwise it's just a bunch of mysterious numbers. And so, what is that correlation of the total and truncal fat to cardiovascular risk factor? And I asked Dr. Moshe Gunnan when I get done here, he can say whatever he can say. I don't know how much he's going to. But I will say this, that that hypothalamus, so critically important when you start talking about body fat. And some of the most challenging patients I've ever seen with obesity as an endocrinologist were patients who had hypothalamic injury, whether it be surgery or an accident, some sort of closed head injury. Very difficult. Why? Because the hypothalamus has afferent and efferent pathways. So there's the efferent pathways. Well, first off, let's start from a hormonal standpoint. There are all these interactions that go on with the hypothalamus. As you know, most of the hormones, after you eat, trigger you to stop eating, right? They increase satiety, decrease hunger. Doesn't work always that well. And why is that? Well, because the forces that are out there to prevent starvation are much stronger than the forces that tell you to reduce your caloric consumption. And you might say, well, that just sounds like political correctness there. You've already said obesity is a disease. You clearly have a bias. I don't think that's true, but okay, let's just go there. Isn't that to say that there's this mismatch between priorities? Folks, as endocrinologists, person has a low blood sugar, what happens? Got to eat. They're getting hot and sweaty and nervous and everything. This is an emergency. This isn't something you put off for a few days. You have hypoglycemia, you got to eat. Those are very strong forces. What about if you have hyperglycemia? Well, you've probably seen patients that blood sugars of 400 milligrams per deciliter don't even know it. Don't feel it, right? Maybe they're urinating a little bit, but it's not that big of a deal. So there's a practical example of exactly how the physiology works in the human body, where there is an imbalance between the forces that resist one thing versus the forces that resist something else. And that's the way it works with obesity. So again, a lot of interconnection between the hypothalamus and the hormones, bidirectional. The hypothalamus puts out hormones or directs hormones, but also it accepts the signaling from other hormones. What about from a neurological standpoint? Well, from an efferent standpoint, a lot of the innervation comes from the vagus nerve. And once you sever that because of injury, that's called CNS starvation. So you severed that signaling that comes from the nervous system, and so the brain goes, I've got to keep eating because I'm starving. Because that neurological signal has been cut. And then on the flip side, the hypothalamus helps facilitate the sympathetic nervous system that has to do with thermogenesis, energy expenditure, increase in blood pressure, stimulate lipolysis and such. So when you add the hormonal changes that take place with hypothalamic injury, and when you add the neurological dysfunction that occurs, and then you throw on top of that immobility, okay, it's no wonder that patients with hypothalamic damage have really a problem with weight. And now if you're going to talk about specifically the spinal cord, well, innervation is necessary for your health, your tissues to grow, right? And that if you have disruption, then these tissues, a lot of the tissues in your body tend to atrophy. So you're going to get paralysis of skeletal and smooth muscle. I mean, that's what spinal cord injury is, right? Paralysis. And then you get somatosensory loss of pain and touch and temperature, reduced physical activity, dysfunction in the autonomic nervous system, because again, the nervous system isn't sending out signals anymore. Reduced lipolysis, and there you're going to have a loss of lean muscle mass. You're going to have a relative increase in adipose tissue mass. And then, in general, there's about a 10 to 12% increase in body fat of patients with spinal cord injury. And sometimes they can have abdominal fat as much as 25% of their total fat. So this is a very unfortunate situation with spinal cord injuries with regard to body composition. Loss of lean body mass, loss of skeletal muscle, and increase in body fat. And here's the second abstract. I thought I may have labeled one of these wrong. I thought one of them was ACE. But anyway, this one is, no, that's the spinal cord injury. I'm not sure what I've done there. Oh, yeah, okay, that's the same one. That's the same one. So maybe we'll talk about that later. So here's body composition. This is the one for ACE. Body composition, cardiometabolic risk with neurodevelopment disabilities. And as you know, again, just as with spinal cord injury, dealing with people who have neurodevelopmental disorders, very challenging, particularly with achieving healthy body weight. And in this particular abstract, they measured body fat or body composition with bioelectrical impedance. And it's a retrospective chart review. And again, I'm not going to say what the conclusions are, but I will say this, and this is intentionally made where you can't read it, but you can get to the article that, it's just in press right now as we speak. But all these effects of all these antipsychotics and such on body weight is just profound. Can have just profound effects. And mood stabilizing medications. Many of them can also have really deleterious effects upon body fat and body fat function with worsening of metabolic parameters. Okay. So what are the reasons why it is that people with neurodevelopment disorders have an increase in body fat? What's going on? Well, lack of routine exercise. Sometimes it's very difficult to say to many of these patients, I want you to get into a routine physical exercise program. I mean, you can try, but that's very challenging. They're on many of these medications I just mentioned that can worsen body fat or body fat function and promote metabolic disease. There's central nervous system involvement. Maybe there's peripheral nervous system involvement that does all the things that I just talked about. What about environmental factors? Availability of food. Well, if you're mainly in a house or you're at home or you're mainly hospitalized or in an institution or whatever, there's going to be greater availability of food. And then what about the food content? Well, if you have loving and caring people there, they're going to want to give the person with neurodevelopment disorder, particularly if it's severe, whatever makes them happy. And what makes people a lot happier, energy-dense foods with lots of salt, lots of sugar, lots of fats, right? And so there are a lot of issues with regard to family dynamics and parental feeding behaviors. You can't blame the parents here, right? You can't do that. Because if that's the one thing that seems to make these patients happy and such, I think we can all understand that. It's the very human aspect of being a physician or being just a member of this planet. And then, of course, there's socioeconomic status and access to quality health care and such. Can you afford the more healthful foods or not? Or is the economic situation such that it's the energy-dense, high salt, high fat, high concentrated sweet thing? So overall, hopefully you've gotten just a little sense from this about the importance of body composition as opposed to just simply weighing patients. Because I think this is applicable not only to just patients who have the diabetes, hypertension, dyslipidemia, but also you're going to see people who are going to really take their health seriously. And you want to be able to have an intelligent conversation with them about their body composition and their muscle mass and the percent body fat and everything, because they're going to be very interested in that. And I think they're going to have an expectation that you at least have some knowledge of that. And then on the flip side, you're going to see patients, either due to immobility or physical inactivity, who may have a BMI that looks not too bad, but their percent body fat is terrible. Okay? And then there's the whole array of issues that arise when you start talking about people, when you start talking about blacks versus whites, or Asian. We just talked about people of Asian descent and whatever. You know, males versus females. You know, a lot of dynamics going on there, a lot of differences, and they all influence what you might expect if you were to do body composition analysis. Okay? And with that, do you want to say anything about these abstracts? Oh, okay. What do you want me to do? Yeah. Oh, just do stop sharing? Mm-hmm. Okay. Okay. All right. Oh, okay, great. Mm-hmm. Okay. I'm sorry, go ahead.
So, sometimes that can be falsely high. For example, if there are like bone spurs or if there's like osteoarthritis. So does the same apply when you're using the DEXA to measure the body fat? Like what if there's extra water retention due to heart failure, or there's bloating, or there's like a surgical scar tissue that is present? So will the DEXA pick up erroneously high visceral fat if there's like a big surgical scar?
Yeah, so the question is, when it comes to percent body fat, if you're measuring by DEXA, we know that there are certain conditions. I'm repeating it in case other people here don't. Okay. We know with DEXA, say for example with bone, they have hyperostosis, or they have certain bone disorders and everything. It may read an increased bone mineral density, which does not necessarily mean that they have healthy bones. Okay? And the same question is there other conditions out there where you can measure body fat, but you just get erroneous values and such. And I am not aware that that's like a major. We've never encountered that. The only time where something like that does come in is, let's take DEXA aside. If you're going to do BOD-POD, or if you're going to do plasmography, if you're going to do that, or if you're going to do bioelectrical impedance, that is very, very dependent upon hydration. Okay, very hydration dependent. So there's all sorts of requirements. You can't be doing a whole lot of exercise and doing a lot of sweating, within 24 hours prior to getting your study. You don't want to be drinking alcohol, because obviously dehydration can occur because of that. So there are a lot of requirements when you start talking about those types of tests, because they do rely, particularly bioelectrical impedance. It's impedance, right? It's measuring the difference in electrical transmission of muscle or body tissues versus fat, right? So that very much relies on whether or not you have water or not water. So in that case, yeah, there's a big difference. But as far as the others, not to my knowledge. Maybe there is. I just don't know any of them off the top of my head. Yeah.
So, are bound to
What?
as weight loss.
Almost invariable. There are some exceptions,
So
yes.
was the modality of weight loss, did they do cardiac training, or did they do because in someone who's like building muscle, you would think that they would actually increase their muscle mass. That muscle would then help them to kind of get rid of the body fat, like eat the body fat in the resting state. If they increase muscle mass.
And okay, I'm still not sure of the question. What's the question?
So you said that when somebody loses weight,
yeah,
they lose the lean mass.
Yes.
So what I'm asking is, if somebody was the modality tested, like did they lose weight? How did they lose weight? By just running on a treadmill or doing?
Oh, I'm with you now. Okay, yeah, I don't know. Oh, that's a very simple question. Okay, so the question is, in the patients that we routinely see, and I've given some exceptions here because those are those ones that are the interesting ones. Okay, but it is most common, even among athletes, that if they lose say 10 to 15 pounds, a big part of that is going to be a loss of fat, okay, because you're having total diminished caloric input, so intake, and so those calories are not going to be available for building of the tissues. It's that simple, okay? Now the question is, these patients that lose both muscle and fat, how did they lose it if they're losing both? And what I would say is, very rarely you're going to see somebody that's going to lose body weight. And I'm specifically saying that the way I mean it. Body weight, not body fat, body muscle, but body weight. Very rarely you're going to see somebody lose weight simply because of physical activity, like physical exercise. That's really hard to do that and not alter your nutritional intake, okay? Usually what people do is they do both, okay? And I would say most of our patients, it's mainly nutritional intervention, okay? Because it's just really hard sometimes to get people to do the physical activity. The extension of that is, what is it a person could do if they're going to have a hypocaloric balance and they're going to lose body tissue like fat and muscle? Is there anything that people can do where you can avoid the loss of muscle, or at least mitigate it, or slow it down? Is there something you can do? And the answer is yes, you absolutely can. And those are the examples that I showed, is resistance training. Engage in resistance training as you're losing weight. Now, of course, you want to do dynamic training as well. I'm not saying that's not important, but it's got to be sort of a balance of both. So yes, you're going to get some weight loss, some fat weight loss, because you've increased energy expenditure, and that's great. But that increase in resistance training and even dynamic training can preserve some of that muscle as are people going through this weight loss. Okay?
And one of the things is a study where was, there used to be the show, The Biggest Loser. In that study, it was not a study, but it was a show, and they studied them. The thing is that they were heavily exercise driven. They used to exercise about 6 to 8 hours a day. And then they studied them, and because they lost as much weight as some of the bariatric surgery procedures. They would have lost 100 pounds. If you take bariatric surgery patients, you will see that they have a huge amount of muscle, in addition to all the fat loss. They have bone mass loss, they have muscle fat, and muscle loss. So, but when you take similar amounts of weight, you're losing 100 pounds, with muscle gain. That was the only study. Unfortunately, when they regained it, when they stopped exercising, they regained the weight, they lost all the muscle, and they ended up being.
Yeah, the thing that you can tell, here's a tip what you can tell patients. So that's kind of the extreme when you have people that are really engaged in heavy physical activity or physical exercise, and that's what I said. There are extreme examples, but here's what you can say. I'll just throw it to you. How many of you? I mean, many of you probably routinely do physical exercise and such, and you've probably been on a treadmill and you're on there and your sweat pouring off of you and everything, and then you look at the amount of calories you burn. It's like 200 calories. It's like 200 or 300 calories. Like what? What? I did all this work and that's what I got. What you can tell people is to help them. And this has been borne out. There's a registry of people who've lost weight and kept it off, okay? And they have a list of the things that they have done in order to keep the weight off. And one of them is routine physical activity. So what is it that routine physical activity is doing? A common thing we tell patients is routine physical activity, physical exercise, very important. Yes, it's going to help you lose the weight, but one of the main things it may do is help you maintain weight loss. Okay, so it's that caloric restriction, it's that healthful nutrition. It's going to get that. It's going to do the most of the heavy lifting. But when it comes to maintaining that weight loss, look, for those, I don't know, I've never talked to you about this. there's this theory out. I say it's a theory. Some people say it's a fact. I still think it's a theory because I don't know if it's true. There's a theory or something you'll hear people talk about is leptin resistance. You ever heard of that term? Okay. So leptin resistance, the way the story goes, is that your fat cells make this leptin, and leptin's supposed to reduce hunger and increase energy expenditure, these types of things, but that there's this part of the brain where there's resistance to that, okay? And so it doesn't work so well. And again, the theory is, what you'll hear is that routine physical activity diminishes leptin resistance. And here's another one at you. And again, you guys probably already know this. What is another hormone that's produced by your body that also has similar effect of leptin on reducing appetite and such? Well, I'll just tell you, insulin. People think that's kind of counterintuitive for a lot of people, but seeing that sense of there have been studies done like intranasal insulin, and at least there was some evidence that it can cause weight loss because somehow they thought it was getting across the blood-brain barrier and whatever. But now you might say, well, yeah, but if our patients with type 2 diabetes mellitus have all this hyperinsulinemia, how come that doesn't work? I don't know. Maybe it's insulin resistance of the brain. I mean, I don't know. I can't explain it, but all these hormones all kind of interact together. But the essential point is this: there are benefits to routine physical activity that have to do with cardiovascular health, have to do with mobility, mental well-being, but also help maintain weight loss. That's my point. Yeah. Let me ask you. Okay. So they say that the CME code is not correct. I don't know how to fix that. Which one is?
Correct.
So what's up there is correct?
Yeah.
All right. Well, I can't. Okay. So anyway, that's what I'm told. That's correct. Whatever code we have in the chat box there, that's correct. Yeah. What's the difference between android fat and visceral adiposity? So android fat is the composite of your superficial abdominal adipose tissue, and then the deep layer of subcutaneous abdominal tissue, and visceral fat. It's all three. Now, again, the story goes, you'll have some people that say the abdominal subcutaneous adipose tissue is pathogenic, and the visceral adipose tissue is pathogenic, and that's the reason waist circumference is going to be pathogenic. But you're going to have other people that say, well, wait a minute, that's true, but not exactly correct, that the superficial abdominal subcutaneous adipose tissue functions more like peripheral subcutaneous adipose tissue. And it is the deeper layer of the subcutaneous adipose tissue in the abdominal region which functions more like visceral adipose tissue. And then I don't know anybody that doesn't think that visceral adipose tissue is a bad thing. Okay, so that's pretty solid. But as I said, the reason both these terms are important is because visceral fat is just the fat that surrounds your visceral organs, right? That's it. So I gave you examples of where people had an increase in android fat but hardly had any visceral fat. As I said, blacks tend to have less visceral adipose tissue, but still can have subcutaneous abdominal adipose tissue. Conversely, patients of Asian descent, maybe their waist circumference is the same as other people, but they have a disproportionate increase in the amount of visceral fat, which is the fat around the organs in the abdomen. So they're two different measures. But to directly answer the question, android fat includes visceral fat, but also includes the subcutaneous adipose tissue in the abdominal region. Okay. Are there any? This is great. It's a great question here. Are there any medications that improve body composition in the pipeline? Well, there's some right now. Many of the anti-obesity drugs that have recently, the semaglutide and liraglutide and those types of things, they increase body fat, but they also reduce android fat and visceral fat. So those work. Now, I think I get where they're going. Like, are there any that kind of disproportionately maybe enhance subcutaneous adipose tissue and maybe have less of an effect or diminish visceral adipose tissue. And yep, there's one class of drugs out there. Back in the day, my goodness, 20 years ago, everything was all about the PPAR alpha gammas. PPAR gammas, those are the thiazolidine diones, right? The PPAR gammas. And we were going to add a PPAR alpha. There were all these drugs, viraglitazar, teziglitazar, and all these drugs, and they all never made it to market because they had cardiovascular side effects and they were just problematic. But anyway, one of the real excitements of these types of drugs is, just as I mentioned before, one of the properties of the PPAR gammas, or the thiazolidine diones, is they increase the proliferation and differentiation of subcutaneous adipose tissue. So you can automatically see that disproportionately you're affecting this and not so much this. So I've often said, if you wanted to come up with a blockbuster drug that improved fat function, it would be a combination of a GLP-1 receptor agonist and a thiazolidine dione. Put those two together and see what happens, right? I mean, that'd be a monster drug because you're improving adipocyte function, but you're reducing the total amount of fat. So that has to disproportionately affect the visceral. I've never really tried that. Okay, but that's so. All right. Does obesity cause types of brain dysfunction? Sure does. I mean, the classic one is if you look at depression. So depression is bidirectional. On the one hand, you have depression that can contribute to the obesity, and you have the obesity that can contribute to depression. Okay, now they're probably they're probably asking more from a hormonal and physiological standpoint, and there probably are. I'm just not, I don't have a prepared talk on that. Okay, but there are all kinds of, as I said, the adipose tissue is very active immune and endocrine organ. And you can even take it one step further. I don't know what your all's opinion about all this emphasis on the microbiome and such are, but there's another example where the gut and the microbiome, it's so active from an immunological and hormonal standpoint and such, and there's all these signaling that can go on from inflammatory responses to certain type of, particularly bacteria that are in the gut. Trillions of organisms in the gut that signal the brain and everything. I mean, I think all that stuff with the microbiome, this is my opinion. I think people got the sense, well, if people with the obesity have a certain percent from QTs, bacteroides, and whatever, and if we could just transplant the right kind of microbiota into these patients, then the obesity is going to go away. Well, they tried that, and it doesn't work. Okay, it doesn't happen. But it is interesting that there's obviously something going on. I mean, I just recently had included in a paper that I published. I was looking at this study where they transplanted the microbiome from people who had jet lag, okay, and they transplanted it into rodents, and the rodents gained body weight. I mean, I think it was a very small study, but anyway, the point is, at least in rodents and such, this whole microbiome story sounds really good. It's just once you get to people, it doesn't work so good. But anyway, the point I was making is that that's just an example of the immunogenicity and of not just body fat, but also the microbiome and such that can affect. A lot of people think there's folks out there with predisposed to obesity because they have hypothalamic inflammation, right? There's yet another example. And as we all know, atherosclerosis is what? An inflammatory process, right? People with the obesity, they have an increase in what? CRP, right? They have an increase in CRP. Again, adipose tissue contributes to immunogenicity. Let's see, what is your opinion on sensitivity, specificity of basal metabolic rate for all electrical impedance instruments? A lot of these, so we do them as well. It's when we do our DEXA reports, printed on the DEXA will be your resting metabolic rate. Okay, your resting metabolic rate. And how did it do that? DEXA. Just an equation, folks. They just took the person's body mass index and put in their age and sex and whatever formula that they used and whatever variables they put in, and they calculate and they give you a number. Okay, so it's not as though DEXA is the same as direct or indirect calorimetry, right? So there's different ways to measure energy expenditure. That's what we report with body composition. We're just reporting calculations. Okay, calculations. Yeah. It's not, yeah. It sounds neat. I mean, you think somebody's doing something really mysterious, but they're just not. It's just math. Right? All right. Very good. So when will you let these people know about your all's abstracts? When can they know about those? The results. So one's in May, and the other one's in June.